Welcome to Black Health Matters. I'm Darryl Armistead, your host. This episode is a Zoom recording of Howard University group session led by Dr. Clive Callender.
Is below 100%. That is abnormal, but it may not be something serious. So what we consider uh, a serious kidney disease is when the GFR is less than 60. So that is where we start to see complications that I spoke to about earlier on. And that is when you have the risk for developing kidney failure over time if your risk factors are not controlled. So the urine test for protein, albumin is a type of protein that it can be released in urine when the kidney is diseased. Normally, you don't see significant amounts of protein in the urine because the filter, the barrier, the filtration unit of the kidneys hold back protein. Protein is a large molecule. It holds back protein in the blood. But when you have protein leaking into the urine, that tells you that that filter is not working well. So think about the filter in your refrigerator that is supposed to remove large particles and small particles. If you start seeing small particles in your drinking water when you fill up a cup from your refrigerator, so the filter is damaged, you have to replace it. So that what happens, that is what protein is like to the kidneys. When you have the protein in the urine in significant amounts, that means the filtration unit of the kidney is not working well. It's damaged. Your kidney function may still be registering at 90% or 100%, but you have that damage. And if you don't do something to treat the underlying cause of that damage, that the kidney, the disease is, or the kidney function will start to decline over time because as that filter is damaged and you have more protein spilling into the urine, that protein spilling into the urine can actually cause more kidney damage. So that is why we evaluate protein in the urine and blood, the serum creatinine. Now, the up-to-date news I'm going to share is people are beginning to see that, there's a flaw in how we are screening for kidney disease in people at the highest risk, like African Americans. That formula I spoke about, the GFR equation, we measure the serum creatinine as a blood test, a lab test, and then we go to a calculator. It's an online calculator, so anybody can even determine their kidney function by putting in any search engine like Google, GFR calculator. I like to use the one from the Kidney Foundation, www.kidney.org, because it gives you educational information about what your numbers are. So when you pull up that GFR calculator, it's going to ask you for your age, your sex, your race, and your of course the creatinine. So the race section, there are two variables, black or non-black, because the reason you have that the race variable is it's a surrogate for your muscle mass. So the teaching is that Black people have more muscle mass than other races or other ethnicities. So the black, that race variable in that equation is a surrogate to say, do you have a high muscle mass or low muscle mass? So we're beginning to realize that it's not every black person it's not every black person that has a high muscle mass. Uh, and and the race question is how you identify yourself. You could be mixed, you could have multiple backgrounds and all that. So it's really flawed to use this race as a surrogate. So people are saying now that we should ignore that race. We can still plug it in, but use the one that is for non-Black for everyone, because it's, race is not a good surrogate for muscle mass. And then there's also a new protein called cystatin C that we can also use that is not affected by somebody's muscle mass or race, that we can also use that is better at estimating the GFR than using the creatinine. And experts say that actually combining the values for both creatinine and cystatin C will give you a more accurate measure of your GFR. So basically, the take-home message here is when you go to your doctor and they tell you what your GFR is. Ask them what the GFR is for non-Black people too, because you want to have both numbers, because your number may lie, your true value may actually lie in between both values that you get. Because if the risk of using just the equation that relies on the Black race is you may overestimate the kidney function in a Black person and ignore the warning signs when they start to decline, so that you can intervene more aggressively and slow the progression of the kidney disease. So those are the two measures for determining how healthy your kidneys are: serum creatinine and the urine protein. The serum creatinine we use to estimate the GFR, and that will tell you what it is. And what are the measures to slow down the loss of kidney function to prevent kidney failure? So we have conditions that we can modify, like if you have diabetes, so controlling your blood sugar with healthy eating, healthy habits, diet and exercise, taking the medications as prescribed by your physician. So it's a partnership between you and your provider to make sure that you're getting the best treatment possible, tailored to you, your preferences. Also, controlling the blood pressure. The single most important thing you can do is controlling the blood pressure. So again, there are medications for that, but also a healthy lifestyle is very important. So eating fresh fruits and vegetables, avoiding processed foods, limiting the intake of salt, exercise or physical activity, limiting alcohol intake, not smoking. All those things have been shown to lower the blood pressure and slow down the progression of kidney disease to kidney failure. There are other things that are very important that you should know. The medications that can cause kidney damage. So there's so many of them out there that you can't possibly remember all of them. But the very common ones that you may get unknowingly, from a drugstore is some painkillers like Motrin, ibuprofen, Aleve. So if you've been diagnosed with kidney disease, you don't want to take those medications, even when prescribed by a physician who may not actually remember what your diagnosis is. Some of them will prescribe it over the phone or something, not looking into your chart. So make sure that whenever you go to buy any medication from the drugstore, either prescribed or non-prescribed, have a conversation with the pharmacist and say, can you tell me if this can cause harm to my kidneys? Or I've been diagnosed with kidney disease. Please tell me whether this causes problems in kidney patients. Also, even if you're on dialysis or if you've received a transplant, there are interactions that can happen. So medications can cause damage to the kidneys, or they may build up, accumulate in kidney failure and cause harm to other parts of the body, because the healthy kidneys would normally excrete that medicine. And if you take it in normal doses, it can accumulate because it's no longer being excreted by the kidney, since you're on dialysis or you have a decreased kidney function, and can accumulate and cause more side effects. So it's always important to have a conversation with the pharmacist, because they can look it up for you, or you tell any doctor writing a prescription or ordering a test that you have kidney disease, you've been diagnosed with kidney disease, or you're on dialysis, you have a kidney transplant. So people are more careful when prescribing medications. I think I'm going to stop here to take some questions, and then I can talk some more depending on the type of questions I get. Dr.
Cheryl Jones, you on the line, you had some questions you wanted to ask.
Yes, I had a question about when you have chronic failure after having the transplanted kidney, having chronic failure with that, but it still has some functions. I wanted to know if you still took the anti-rejection medicine while still on dialysis, or do they normally just take you off of those medications?
We normally take off those medications, but not suddenly. We wean the patient off the medications. So the ones that we usually stop, we try to wean the prednisone slowly if you're on prednisone, because stopping prednisone suddenly may lead to what we call adrenal crisis, where your blood pressure drops too low, you feel very sick, you feel very bad. So we wean the prednisone. And this is usually over months. Usually by the end of the first year after being back on dialysis, we stop all the medications. The tacrolimus also we wean slowly, because the danger in stopping everything suddenly is you could have a hyperacute rejection. You can have an acute rejection episode that will make you very sick, or a fulminant, that's the right term, a fulminant rejection that can make you very sick. That is like having an infection. You can end up in the hospital where they'll have to do emergency surgery to remove that kidney. So we do stop them eventually, but slowly, and it also depends on the patient, So some people have built tolerance to those medications that we could stop, after 3 months. Some people may take up to 12 months before we stop everything, but it's gradual. The one we stop right away is the mycophenolate. So people on mycophenolate, we can stop right away because they actually develop side effects when they start dialysis. A lot of them have diarrhea, vomiting, so stomach upset with the mycophenolate, because that tends to build up. But tacrolimus and prednisone, we are more gradual with withdrawing those medications.
Berlene, did you have any questions? Berlene Freeman?
She's muted. I don't think.
She's muted.
Unmute, Perlene.
I'm
There you go.
sorry. I have some questions, but not right now.
Okay, anybody else have any questions? If not, one of the things that I've noted is that, now that we have patients who've been transplanted 20, 30, and even 40 years, the way they present to the, after they, let's say they get a rejection and they wind up back on dialysis, the complications that they present with are different because early on you had people who lost kidneys after 5 and 10 years, but it's a different group of complications for people who've lost their kidneys after 20, 30, and 40 years. And so it makes the diagnosis and also the decision as to whether or not you need to take out the kidney different than it used to be. And so this is, how have you had to address this problem as you see the old transplant patients who have rejection who find themselves on dialysis after 20, 30 years after transplant?
I haven't really referred anybody for transplant nephrectomy, except if they're having symptoms like they're having hematuria, or so blood in the urine, or pain in that, or frequent infections or pain in that allograft. A lot of them, still have the kidney in place, but some, like you suggested, some people, especially if it's acute rejection that leads to kidney failure, a lot of them tend to have severe anemia and infections that follow. Those who have chronic rejection, usually, it's over time that, their kidneys fail. And then when they go on dialysis, they tolerate withdrawal of medications better. Most of them don't have any complications or symptoms after that. But those who have acute rejection prior to going back to dialysis, they're the ones who tend to eventually require nephrectomy.
Oh, I have a good question. If you find out that there's a problem on the carotid artery, can you go in and take the kidney from that area and put it to another area of the aorta?
That's kind of a surgical question. And the answer is yes, you can. Technically, you can.
Wow.
I mean, it can be done. The question is whether or not you want to do it. You would only do it in a situation where you have pretty normal kidney function.
Normal.
Yeah.
Okay.
In other words, not when you have a chronic rejection, but if you have a perfectly normal kidney that is otherwise okay, but the blood vessel is the problem, and you would
No.
know that by doing special X-rays, which would tell you that it's the artery that is the problem. It would only be then that you would want to do that kind of surgery.
Okay.
Yeah, because when you have long-term high blood pressure, long-term kidney disease, it affects, and as Dr. Murray knows, the calcium phosphorus ratio affects the blood vessels, and it can damage the blood vessels and make them difficult to sew. I remember the second transplant I did was a patient who'd been on dialysis for about 10 years, and her blood vessels were just damaged by the calcium phosphorus ratios, and you could hardly put clamps on the blood vessels without them collapsing.
Yeah, to piggyback on that, yeah, so absolutely right. A lot of our patients, young, middle-aged, when they go to have a transplant evaluation, you refer them to transplant center and they get x-rays, their blood vessels light up. Some people say like a Christmas tree, calcium, yeah, the calcium building up in those blood vessels. That is why, we monitor the calcium and phosphorus every month, and we'll tell patients, take your binders, come to dialysis, and control your diet. So the 3 days for phosphorus, because phosphorus is as guilty as calcium in terms of causing that calcification, that calcium to build up in blood vessels. It makes it difficult for the surgeon to make that connection between vessels, and even when it's successful, it may break down, eventually. So, I've seen a couple of people being denied transplant because they're just post-surgical candidates. If the surgeon cannot treat, can't find healthy blood vessels to make that connection, that anastomosis. So it's really important, if you're on dialysis and waiting for a kidney transplant, pay attention to your calcium and phosphorus, both numbers. You want both numbers to be at the goal set for you, which is normal levels, the normal level for the lab, okay, so that you don't have such complications.
One question I would ask you, osteoporosis is a common problem for transplant patients who've been on steroids. When these patients come back to you after they've lost their kidneys, do you have many problems with osteoporosis and fractures and that kind of things?
Yes, so yeah, you're right. So the kidney disease itself causes bone disease, or kidney failure causes bone disease. So it's one of the complications. Anemia, bone disease, those are the two big complications, plus cardiovascular disease, so unhealthy blood vessels and heart disease. Now, osteoporosis, we treat it differently in kidney patients because the bone disease that they have is different from osteoporosis, but they can have both osteoporosis and what we call renal osteodystrophy, which is basically porous bones that are not dense enough because of the high parathyroid hormone level, high phosphorus, low calcium. So all, those three, minerals can, so calcium and phosphorus, the minerals, and the parathyroid hormone, the hormone, can impact the bone in such a way that it can lead to fractures. So that is why we check the parathyroid hormone level too on dialysis. And the treatment we give is the active vitamin D. So people who don't have kidney problems, who have osteoporosis, take regular vitamin D over the counter, calcium and vitamin D. We don't give kidney patients calcium for obvious reasons. The calcium goes in the blood vessel. It doesn't go in the right place in the bone. What we give them is the active vitamin D that tries to suppress that parathyroid hormone level that is very high because of the kidney failure. And then it helps to keep the bones healthy. So that's how we treat osteoporosis and renal osteodystrophy in kidney failure patients. We give the active vitamin D. Some patients who have low vitamin D levels, We also give them the over-the-counter vitamin D, the vitamin D3. So 2 types of vitamin D to keep the bones healthy.
Donald Hughes has a question. Donald Hughes has a question. Unmute, Donald.
Yes, I'm new to this. I received the flyer. I was wondering, how long has this group been going on, and does Howard have a transplant center now, or what?
This group has been going on since 1975, and we stopped doing transplants at Howard in 2010. So if you need a transplant, the nephrologist would refer you to George Washington or Georgetown.
Mm-hmm.
Both do kidney transplant.
So does the person still get renal care at Howard?
Yes.
Oh, well, that's what Dr. Murray has been doing for the last 16 years, but they started dialysis in 1974.
Yes,
No, actually, 1973. When was it, Dr. Murray? I think it's 73.
Yes, about 73, yes, 1973.
So you stopped your transplant program. So do you have patients that are on the transplant list that are your patients, or are these patients referred out?
Yes, so we have enough, even though we don't have a kidney transplant surgery program, we have a kidney program. So we have physicians, nephrologists who take care of kidney patients. And we also have a dialysis unit here at Howard. So we have patients on the wait list at George Washington Hospital, Georgetown Washington Hospital Center, University of Maryland, Hopkins. We refer everywhere, Fairfax, Innova Fairfax, University of Virginia. So when we see a patient who is progressing to kidney failure, educate them on the different treatments for kidney failure. And transplant is the best treatment for kidney failure. Dialysis is only a bridge to transplantation. If you don't have somebody to donate a kidney to you and you develop symptoms of kidney failure, you start dialysis while you're waiting on the wait list. So what we do is, after educating our patients, when they determine, some of them will say they want to go to George Washington because there's a metro stop right in front of the hospital, it's accessible. We send a referral to George Washington and they contact the patient. And we keep following up to make sure they contact the patient in a timely manner. The patient goes over there, undergoes evaluation, so medical evaluation, psychological evaluation, education, and all that. And then when they order all those tests, we help our patients complete the workup. So CT scans, evaluation by a heart specialist, x-rays, all that stuff. We help them complete all that. And the transplant center meets, views all that data and says this person is suitable for kidney transplant. They don't have any medical problems that would make the surgery difficult. No contraindication. They list them and they tell us, they write us a letter and tell us the patient is listed. And our duty is to draw blood once a month that will send to the transplant center. So the blood is called a PRA, panel reactive antibody, that was sent to them every month to keep, just to check if patients have developed antibodies that would cause problems with transplant in the future. And we keep, every month we review our transplant list. Actually, I should say now that the federal government has gotten involved with so much. I mean, it's always been a federal government program, but January this year, they have, President Trump signed the ESRD Treatment Choice Act in 2019, the summer of 2019. The purpose of this act is to make transplantation more accessible to patients. And this was because the kidney community lobbied for that. We wanted to make it easy for everyone, regardless of your socioeconomic status, your ethnicity, whatever, to make it more accessible to transplant patients. So right now, as a dialysis center, the evaluate you based on the number of your patients, the percent of patients that are on the wait list for transplant. You know, it used to be in the past that people would say, oh, you know, dialysis companies don't like to refer patients for transplant because they want to make money off patients remaining on dialysis. But that's not the case anymore, because if there's an incentive really now to make sure that patients are on the, you know, most of our patients are listed. So we work aggressively. There are centers that will tell us, oh, your patient is overweight, we don't want to list them. We send them to, we have a bariatric program here at Howard too. We send them there for dietary counseling, not for the surgery part of it, but counseling to make right food choices. And they lose the weight. We work with them. We have social workers and dietitians lose that weight and get back on, get on the transplant list.
Is there a social worker on the dialysis team or renal failure team at Howard?
Yes. And yes, we have 2 social workers.
And in conjunction with that, is the screening done at Howard and the referral made to the other transplant centers in DC? Or because, you know, you could make a referral from Howard, you could feel that the patient is really ready for transplant, and someone at one of the other sites say, no, this person is not ready for transplant. I mean, if you get 5 physicians in a room, they all have a different approach. So in the event of something like that happening, how is that normally dealt with? Because see, you don't have your own, you're not the dialysis center, so the person is not making a decision that, yes, we can go ahead and transplant this patient. At someplace else may decide that the patient is not suitable. And my last question is, how is the politics around dialysis nowadays and transplant? Because someone may want to make their numbers look good. Patient may be at risk, but may be a very credible risk that someone would take a chance on, maybe at Howard. And at another facility, they wouldn't, because they want their numbers to look good. So I'm concerned about those questions, but mostly concerned about how are the dynamics of the politics when Howard is kind of like a facility that does everything a patient needs except the actual transplant, or is that in the pipeline somewhere down the line?
So let me answer the most important question to you first, which is if somebody says, a transplant center says a patient is not suitable, you know, what do we do? So usually they give their reason. And depending on the reason, and we have a conversation, we don't just accept the letter. So like I said, when they say a patient is not suitable because they're overweight, that is something that can be modified. So, and when they say overweight, they give you a specific BMI, the body mass index that they want the patient to be under for them to transplant, and it's center specific. And the good news is we have a choice. So in the DMV area, we have at least 8 different transplant centers we can send the patients. So if one center says no, we send to another one. Okay, so I have a patient that went to Innova Fairfax and got transplanted. They said his BMI was too high. And this was even after he had had surgery, weight loss, weight reduction surgery. And some will say, oh, well, the patient was belligerent when they came to the transplant center. And then I have a conversation with the team. So we don't just accept a rejection letter. We have a conversation, find out what the reason is, and if it's modifiable. So we've had luck with that. Now, there are cases where we agree with, we wouldn't even refer the patient because their surgical risk is very high, and it's mostly because of heart disease. So people who have very poor heart function where they may not survive the surgery, we don't refer. And if the person goes on their own, because the patient can go on their own and contact the transplant center, and we get that rejection letter, we agree, and we don't pursue that. Now, in terms of the politics, again, there are many centers, they're all competing with each other. So if our patient, we don't refer, goes and they tell us, oh, the patient is listed and we think the patient is not suitable for X, Y, Z reasons, we talk to them about that and also talk to the patient and tell them why we think it's a risk doing that. Usually it's because of non-compliance. Maybe the patient who doesn't take their medications regularly, and we think that if you transplant them, they may reject that kidney. So it's something that with counseling, the patient may change their behavior. And most transplant centers will say, okay, let's watch you for 6 months and see, if we get a favorable report in terms of your compliance. And the other question you asked is, will Howard have a transplant center open up in the near future? I would hope so. I don't know if you're aware, Howard is being run by the Adventist group, Adventist Hospital Group. So I would hope so that in future they have some priorities now, some basic things they need to get off running smoothly, but it's something I would want to discuss with them in the near future too. I don't know if you answered all your questions.
Dr. Murray, this is John
Yes.
Tatum. In terms of the politics, doesn't UNOS eliminate some of the politics behind issuing organs such as kidneys?
Yes, UNOS does, and if you want to, patients can be listed in multiple transplant centers too. There doesn't have to be one transplant center. And yes, UNOS with their revised criteria, and that is also part of that, the ETC, the ESRD Treatment Choice Act that was signed in 2019 to increase access to transplantation by putting those who have been on dialysis longer at the top of the list. Also by using other criteria so you don't discard kidneys that could actually be beneficial to some people. So there's a lot in that, that executive order that was signed. The blanket name for it was Advancing American Kidney Health. So there's going to be, because of the organ shortage, you're going to limit a waste of organs by not discarding organs for, very trivial reasons. So people, if an organ, if an organ is harvested and it's been on ice for a long period of time, you don't discard it because of that or because it has hepatitis C. There's treatment for hepatitis C now. You can put it in somebody with hepatitis C and treat the hepatitis C. So there are different things they're doing now to increase organ availability to people on dialysis. Again, because we know that transplant is the best treatment. Dialysis is not really, doing dialysis 3 times a week is not what your body needs. Your body needs actually elimination of waste every single day, not 3 times a week. So they're also increasing access to home therapies, so you can do dialysis at home every day. So keeping that in mind, everybody's working together. I don't think there's much politics going on now. And, I've had patients transferred to other transplant centers if I'm not happy with what one transplant center is doing.
Dr. Murray.
Yeah.
Dr. Murray, this is Maya. I'm really enjoying this.
Hi, Maya.
So nice to meet you. I'm enjoying this, and I am shocked. I used to work in dialysis unit. The unit has come a long way. Congratulations. My question is, we got some patients, they say, well, I don't want kidney transplant. So are they, they have to have it, or if they don't want it, then that you don't have to do it. What is the policy?
So it's always a patient's choice. In America, is the freedom. Everybody has a choice.
Oh.
There are some countries where, not transplant is, mandatory, but the way you do dialysis, the government forces, you have to give a reason for a patient not doing home dialysis. I think it's Australia, you know, but a transplantation or any form of treatment or no treatment, the patients who don't even want any treatment at all, you know, it's always a patient's choice. But when a patient I feel is suitable for transplant tells me they don't want it, I want to find out why. It may be because of a myth, you know, a misconception. So I find out why and educate them. Okay. It's the time is really usually very short to give adequate education to patients. So we give them the basic information, the benefits and the risk. Transplant has its risks too, so we give benefits and risk of the different treatments. We start even before they get to dialysis. If they come to the office, if it's somebody who we meet in the emergency room, they still get the same education, even though we put them on dialysis. And they can always, you know, switch later on. So we give them education, and we have lobby day where different transplant centers will come in. That this was before the pandemic. They would come in and talk about transplant.
Wow.
Yeah, so we give, and then, you know, we give as a lobby day, the general talk, and then individual. And even after education and all that, the patients who still say, no, they don't want it. You know, most will say yes, they want it, but there's still patients who will say no, they just don't want it. You know, they will respect their wishes. And every year we update their status. We go back to them. We don't stop and forget. We go back to them every year and say, have you changed their mind?
Nice.
Yeah, so it's required as part of their plan of care. You know, dialysis, you know, the ESRD program is a CMS program. So there's so much oversight on what's going on, what you do and all that, we are held accountable, the providers, so the physicians, the dialysis staff, the company that runs the dialysis, they have different quality metrics that they grade us by. So we do all these things just to make sure that we're not missing anyone.
Well, Dr. Murray, thank you so much. You've done a superb job of addressing the questions that have been put to you. One of the great things that happened just yesterday was that, well, it didn't happen yesterday, it happened last week, I think, was that they finally signed the immunosuppressive medication act, which allows transplant patients to be covered for their medications as long as they're transplanted, which didn't exist before. So this is a major breakthrough. But anyway, I'd like to thank you for doing such a wonderful job. Any other comments?
Thank you so much for inviting me.
I have a question.
Oh, okay. Yes.
I have a question. I've done a lot of work in implications of health and cultural environments. Given that health occurs within a cultural context, and there is evidence that treatments that are done with cultural sensitivity and that kind of thing have more of a chance of having positive outcomes. Are there any studies that have been done comparing, say, treatments that are done at Howard with kidney patients, dialysis, et cetera, versus other locations? I'd just be interested in that. I know that physicians who are familiar with a person's cultural background and lifestyles, et cetera, have better outcomes with their patients than those that don't.
That's a very good question. I'm not aware of any study being done in particular, being done at Howard in particular compared to others, but there are studies that have looked at what they say, cultural competence or sensitivity around health issues. Yes, I know there's a doctor at Hopkins who does that. Her first name is Deidre, I don't remember her last name now, who has looked at that too, you know, the impact of, you know, cultural, and not just cultural, but even religious beliefs, you know, healthcare disparity and all that. And you're right, you know, people are more likely to trust and accept information coming from people who share the same values and beliefs as them, or even people who look like them, you know. So I don't know if you signed on earlier on, I was telling Dr. Callender that the United Network for Organ Sharing, UNOS, which is a nonprofit private organization, that runs the transplant program in the country, and in the allocation of organs in the country, contacted me, and they want to partner with Howard as an HBCU in promoting awareness, education, research, different things, you know. So this is something we may have to also look at, you know, the hesitancy regarding signing up for things like this in a transplant. There's still a lot of hesitancy, especially in organ donation. You know, I'm not even talking about living organ donation, but deceased. So putting on your driver's license that you want to be an organ donor.
Mhm.
A lot of Black people wouldn't do that because of fear that they wouldn't get the care they need if they happen to be in an accident and they are still not dead. They think that, you know, they may be neglected, you know, and not offered care to save their lives because they want their organs, you know, stuff like that. So, and it's with good reason too, given the history of research in this country, you know. So I'm a big person. I'm a big advocate of listening to everyone and understanding their position on things, you know, whether they're for or against, and trying to tackle their concerns, you know, one at a time.
Mr. Hughes' hand is up again. Donald Hughes' hand is up.
My question is, in this region, is MedStar, George Washington, and Nova the transplant centers in this region, or are there others?
So we'll include Maryland, University of Maryland, and Johns Hopkins. Yes.
They're in the same region as DC?
Mhm.
Yes, yeah. So in the DC metro area, yeah. So DC metro area, we have George Washington, the MedStar Group, which is Georgetown and Hospital Center, Innova Fairfax, University of Maryland, and Hopkins. You know, even though they are further north, but you know, those are the areas where most of our patients are referred to. Some go also to UVA, University of Virginia, which is, you know, further west. Yeah, but in Washington, DC is two centers really, MedStar and George Washington.
Cheryl Jones has her hand up.
Yes, I just have a question. Do you work with peritoneal dialysis patients?
Yes. So Howard Dialysis Center has in-center hemodialysis and peritoneal dialysis. We don't have the home hemodialysis, but we have a sister clinic that has home hemodialysis. When I say sister clinic, Howard is a joint venture between American Renal Associates, a mid-sized dialysis organization. They also own Capital Dialysis that has a home hemodialysis. So our patients who we just referred a patient to them, you know, last year for home hemodialysis, and we still follow them. So the Howard physicians, the faculty at Howard, we go to different centers, go to different clinics.
One question I have, Dr. Murray, we had a guy that was transplanted at Howard, I believe, and his kidney failed. He got a transplanted kidney. Now he's got 3 kidneys total in his body. And then that kidney failed and he got another kidney. At this point, he has 4 kidneys in his body and one of them is working. So what is the issue about leaving kidneys in or taking them out?
Oh, Dr. Callender, I'll let you
That's a surgical issue. Our feeling is that if you don't have any of the complications that Dr. Murray mentioned before, you don't have intractable hypertension, you don't have urinary tract infection, intractable hematuria, or rupture of the kidney, we leave the kidneys in place unless you have some complication. If you have no complications, we don't take out the kidney.
Okay, thank you.
Well, thank you very much, Dr. Murray. We've taken up a lot of your time.
Well, thank you for inviting me.
But people are so interested, and you did such a great job that it's gone longer than I planned for it. That's
Okay.
because it was so interesting and so well done. So
Yeah,
thank you so much.
thank you. I enjoyed the discussion too. Okay.
Okay.
Bye. Thank you.
Bye.
I guess, John, you want to start? We've got some time left for some of the papers we're going to show. This is an interesting article that alleges, I say. Now, this is a musical group, by the way. And so you have some biases. But this study suggests that increase your IQ by 10%. And so, and I think this is interesting because there's so many among our ethnic group that are musically inclined. And so to say that the new musician's IQ went up 10 points is saying a lot. But that's and many of us, I guess, took piano lessons and abandoned them early on, and others continued. But piano practice and practicing your instrument, whether it's voice or other, is interesting. In this group, I'd say we have about half the group are musically inclined. So we have a little bias here.
Yeah, Dr. Callender, really quickly, at the top of this page, there's a link to a video, which is really awesome. If you could get a chance to watch that, it's really cool.
Okay, all right.
Dr. Callender, there's also interesting research to the relationship between music and cognitive decline. And it says that one of the last places in your brain to decline is the center that stores music. And people with Alzheimer's and other dementias can relate to music, or they come alive when they hear familiar music as opposed to other things. So, and it also learning an instrument will help, they think will help prevent the onset of dementia.
That's a very interesting point. And it's amazing. I think John Buchanan talked about an interesting observation that you made, didn't you?
Absolutely. My mother was very ill with Alzheimer's, and she was ready to go on hospice, and we had a harpist come in and played music for her, and the next day she was up and walking around. That was unbelievable. Really, I mean, music therapy is a big deal nowadays.
Yeah. It's amazing. I've seen that also in some patients who you give them the music that they grew up with, and suddenly they're different people. Yeah. Okay.
There's also a response. When I was teaching it, it's called the Mozart Effect. Mothers would put headphones on their stomach while they're pregnant, and so to increase the IQ of the infant. And not our particular culture, but other cultures, they do that. It's called the Mozart Effect, hoping that the fetal will acquire some of these musical attributes and they would be more intelligent. I see that Dr. Walton has also heard of this.
Yeah, I think that my dad was used to believe that stuff. He's a Barbadian guy, but yeah, he surrounded us before and after with music.
Well, it worked, didn't it?
Yeah, it did. Okay. This is another article on Dr. Fauci, who's become a legend, about side effects that mean your vaccine is working. And he has them listed in terms of frequency. And implies that if you have these side effects, then you know that your vaccine is effective. And he articulates from bottom to the top: first, joint pain, which is less common than the headache, which is common. And see, 64% of patients had headaches. And then fatigue, which some people don't recognize as a very important side effect of the vaccine. And then number one, of course, is pain at the injection site, which 92% of people. How many of you have not had the vaccine?
I didn't.
I have
I
not.
haven't.
I
I
haven't.
haven't had it yet.
Haven't had it.
Oh, okay. So so about half of the group have had it, or is that about it? Or is
Yeah,
it? Yeah. Okay. All right.
I get my second one next week.
Yeah. Okay. So somewhere in different stages. Huh?
Yeah.
Dr. Callender, how is Howard University? Because they stopped giving the first dose, they're only giving the second. Have they resumed yet?
No, they gave everybody got the first dose, the second
I
dose.
know, but for a period when people tried to get
No,
on.
but what you're saying is that there was a vaccine shortage,
Right.
and so they stopped. And I guess your question is, have they started again giving out the vaccine? And I don't know the answer to that.
Oh, okay.
Dr. Callender, isn't that at Howard for DC residents only?
Yes.
No, it's not. It's for patients who go to the doctor there. So it doesn't matter where you're from. So you could be from Maryland or Virginia. If your doctor is a doctor there, and you're under the practice plan, then yes. So it's not only for DC people. It's for people who are treated at Howard, and people who are at Howard from all over the DC metro area.
Dr. Callender, if Howard isn't giving vaccines now, but they soon will start due to their supply, will it be Pfizer again, or are they getting something else, or would you know?
So far, it would be Pfizer, because that's all that they've had so far. As we know, around the corner are AstraZeneca and Johnson & Johnson, but they aren't approved yet. So it'd be Pfizer.
No, I live in Montgomery County, doctor, and I cannot go there, I guess. I don't have a doctor at Howard.
Well, I guess if you say you don't have a doctor at Howard, I guess it's not appropriate. It's really for people who are associated. The fact that you're with us in the group, you could probably use me as your doctor if you wanted to. But,
Oh, okay. Thank you.
Yeah.
Thank you.
and that's what when I told the people in the group, I told them to use my name because I'm a member of the faculty practice plan. So
If we had an appointment and there was no vaccine when we got there, do you know if we will be recontacted or?
you should be, but as soon as I know that the vaccine is available, they'll send the information to me. I'll send it to you.
Okay, great. Thank you.
Thank you, doctor. Thank you for your kindness.
Dr. Callender, what I have heard about Howard is that, as you said earlier, they have finished giving out the first round. And so now they're working on the second round for those people who got the first round. But they are not, I don't believe that they are in the process of starting a second first round.
They are.
Until they finish all the people they need to cover for the second round.
It's a matter of getting the vaccine, period. So if they get the vaccine, they'll start a second round. So of course you have to use the vaccine you have to complete the first round. But after that, and there will be a second because DC is committed to it. So and all the vaccine they get is from the district. So yeah, there'll be a second round. The only question is when.
Yeah.
Okay. Now this is an interesting article because it's not what you think. And what it's saying is that there's information that Johnson & Johnson and AstraZeneca shouldn't be used for people over 65 yet. That's just because they haven't done it. But Moderna and Pfizer, of course, that's not true. But they're specifically talking about AstraZeneca.
Oh
and,
my gosh.
Because they didn't have as many seniors in their initial clinical trials. They're not saying necessarily that it's bad. It's just that their studies haven't had as many seniors as the other studies have. And we know, of course, that its efficacy rate is 70%, in contrast to Moderna and Pfizer, which are 95%. But it's not even approved here in the United States, so it's not an issue. But it's good to see this article because at least you know that things are underway, and you know that there's a difference between the viruses. I mean, the vaccine, difference between the vaccines. And this is an interesting question. What happens if you skip or delay the second COVID-19 vaccine dose? Suppose you have a snowstorm and you can't get the vaccine on the date that you wanted, it doesn't make a difference.
Wow.
Well, we know that the one shot is only about 52% effective, but with both shots, it's 95% effective. But in terms of delay, you can see here that you can get the second dose as long as 40 days after. So a couple of days doesn't really matter that much. But I think everybody should get 2 shots so that you can be 95% protected. Any questions about any of that? Now, this is what Pfizer CEO vows to speed up vaccine development so that we can get away from having all these people who are postponed. And the hope and expectation is that that will come to pass. Promises, promises. Yeah. So the other thing is that, of course, the hope is that Johnson & Johnson, which is a single dose, although its efficacy is around 66%. The Novavax vaccine is 89% in outside the United States. And that is being used here as well. So that's another vaccine that's coming around the pike. Novavax is still in clinical trials, as are some of the others. So right now, the ones that have passed are the Moderna and Pfizer, and the others are still coming. Now, this is a study that is bothersome, and because you want to know why the Black Americans still left behind.
Yeah.
Is it because they don't want to get it, or is it because that they're not given the vaccine? And it's an interesting question because this is a demonstration of how it looked. And you can see in every instance, it's much lower in our ethnic group. The question is that because of how we want it to be, or is it because we are discriminated against? And I'm not sure of the answer. And that remains to be seen. So we need to really find out, especially since we're more likely to die.
Yeah, that's right.
Yeah, but why are we still so reluctant? That's the question.
A lot of it isn't reluctance. It's we don't have access to computers, Wi-Fi,
Yeah.
et cetera. And that's the
That's
way
right.
a lot of the information is being disseminated.
And I think the other reason is that there are a lot of people who are a lot more facile with computers. And so when they make the announcement, by the time some of us get to it, it's already closed.
That's
And,
right.
and
Yeah.
so the issue that you raise is an
Yeah.
excellent one. And so with time, we need to make other sites available, such as churches and other locations, so that the information gets to everyone. There's still people who are not computer literate.
Right.
And there's some people who are computer literate but aren't facile with a computer. And if you're slow, as Buchanan found out, you don't get vaccinated.
Right.
Yeah. So we've got a long way to understanding the fact that everybody is not entitled and that people are being left out. And so we've got to do better. So, but we also have to ensure that the people who want to get the vaccine, and that has not been determined as yet either.
It's part of that cultural context again, though, too. We as a people generally don't have the luxury of time like other people do to sit in front of our computers waiting for the message.
And the moment it comes in, boom.
Yeah.
Right. That's right. That's not our concept.
You know, in DC,
Callender, did you hear that they're working on CVS and Walgreens
That's correct.
giving out the vaccine?
That's Biden's plan.
we have an article about that coming up.
Yeah, right.
Plus, they're opening up a major area, the Six Flags amusement
Right.
park will be open tomorrow, I think, for vaccines.
Yeah, we got a lot of work to do. Okay.
Also, Dr. Callender, I want to say that in Washington, D.C. area, the Spanish journalists, young people, they're helping the older Spanish people to get the flu shots because older Spanish people don't know how to use a computer and all that.
Yeah, that's good. That's good.
Yeah.
You know, also in DC, they stopped allowing people in my ward to get the vaccine because my ward has the lowest rate of death and infection from COVID in the city. So we've been eliminated from even signing up for the vaccine for the past 2 weeks now. I think next week it'll be open to everybody in the city. But your point is well taken. The people in this area economically probably better off. They've got 10 kids. All 10 kids have cell phones, and all of the cell phones have internet, and everybody at 9 o'clock when they come open. I mean, they had 1,800 vaccinations gone in 10 minutes.
Yeah.
It's amazing.
Yeah, it is. Yeah.
Anyway.
Dr. Callender, I'm still finding associates, people that I talk to daily or just once in a while. It seems like Blacks are saying, I'm not taking the shot, are you? As if a persuasion. And they'll look at you, you say, you've taken the shot, and they'll say, well, I said, I'm still here alive. But it's just like they're trying to talk you not into taking. I'm not taking it, so you shouldn't either. You know, I'm hearing that type of talk among our culture.
Yeah, I'm afraid that when push comes to shove, that is going to be an underlying issue that we're going to have to overcome.
But a lot of people I'm talking to now, that was their stance in the beginning, but now they're changing their mind, looking more into it, registering, trying to get the shot, but unable to get it right now. They're changing their mind about it.
That's good to hear. That's good.
It's hard to erase that Tuskegee Institute thing out of some people's mind.
Or never. It'll never get out of the mind because it's a reality. So we just have to overcome it. Just got to educate and remind people that COVID kills. and we would like to be alive. Can cold weather make you sick? And this talks about why it is that in the cold weather we need flu shots. You go down, scroll down, John. John? Yes, scroll down. Now, you know, because we have all these viral infections in the cold weather, you almost think that it's the cold weather that does it. You know, and it makes sense. The fact that it's cold outside, and even though the viruses aren't any less stable, but we certainly do get sicker in the cold weather. And the question is, how responsible is that temperature for what we get? And the impact of the coldness on the mucous membranes make you more susceptible. And the reason that they lock us down is that one of the things is that we spread it by being closer to one another, whether it's in the subways, public transportation, or going to places where a lot of people are.
Is this a good time to get the second flu shot?
Say what?
Is this a good time to get this another flu shot if you already had one, say in October? Is this a good time to get another one?
It makes sense. It makes sense. And I don't know if anybody has researched it, but I know my doctor felt that if you get a shot in October, that you're more susceptible. And it's interesting that you would bring that up. But yeah, some people think that if you got a shot in October or September, that you might do well with getting a second shot.
I thought October was the time that they suggested you get it. Prior to October, I thought was bad.
Well, actually, November is the peaks in November and December. So they were recommending that you get it in October, but there's some doctors who feel that those who get it in October, that especially older people get it in October, that some of that immunity may wear off by February and March. That's I don't think there's any data that proves it, but there are people that believe that, especially in older people over 65, that may be an issue, that a second dose might help you.
Dr. Callender, they were saying to wait 2 weeks after you get a flu shot to get your second coronavirus shot, or the other way around. If you're going to get another flu shot, wait 2 weeks after the previous
yeah, right.
one.
Right.
Okay, and one other thing, it's hard to cast out the sayings that your mother said, because my mother told me to put a coat on or I'll catch the flu. And I told my children, put a coat on or you'll catch a cold. And those things have been ingrained in us, just like tie your shoes before so you won't trip. We say those things and they really don't happen, but I really believed it happened. So, you know, this article is a nice article, but what I don't know, you know, you can't say that your mama told you something that was
I think it's generational. My kids do not wear coats, and you have to beg them to put a hat on. And this is how their parents, my son, have raised them. They go out in the cold and they have a jacket on. We're fine. They think I'm crazy. So if it works for them, I mean, I guess it's individual. They don't get colds.
Well,
but I thought they did when they come down with a cold. Did you put your coat on? Did you put your hat on? Did you bundled up?
No, I guess they're healthy. They don't get a cold, even with the snow, shoveling snow. Put your coat on. Grandma, I don't need it.
Hey, Dr.
Kids now
Callender,
learn that colds are caused by a virus instead of not wearing a coat.
Dr. Callender, will your insurance company pay for the second flu shot?
Not that I know of. I don't, there's no medical indication. As I said, that's a presumption that some people have made. I don't believe that there's any evidence yet, especially in the older population, because I don't know that it's been studied. And so if it's experimental, they're not going to pay for it.
Mm.
This is Fauci's come under attack because of this one. And all he was suggesting is that the more layered you are, the better off you are. And if you got a low quality mask, then maybe a second mask is good. If you got a high quality mask, you don't need a second one. And I think that's what he was addressing. The fact that if you got a mask that's not so good, having a double mask might help. But if you got a mask that's effective, you don't need double. And there's a lot of evidence that some of these cloth masks that are not filtered, are not, tests have demonstrated that they're not effective enough. And so the goal is to get better, more effective masks. We have more effective masks that have filters, and not just to have cloth masks that have no filters. Any comment or questions? Yeah, look at this one. Wear disposable masks under your cloth mask. Because of some of these masks are for style.
Yeah.
You see some of these basketball players, they have these stylish masks,
Right.
which they wear improperly. But anyway, they wear them. So.
I just had a comment. Sometimes I wear a double mask and the face shield, depending on where I'm going. You know.
Well, that's safe. That's safe.
Yeah.
That's safe. Now, this is an interesting one. And here again, this is just like the other issue about the AstraZeneca. They didn't do any studies on enough seniors for AstraZeneca, and for Moderna and Pfizer, they didn't do any studies on pregnant women. So until they've done it, you can't recommend it because of lack of information, lack of data. So when they have done it, then you can preach about it. Right now, the data is not there. And it's interesting. They did have some pregnant women in there, but not enough to really draw any conclusions. So it's just like transplant patients and dialysis patients. There weren't a whole lot of them on the clinical trials, but because they are more likely to die if they get the infection, most nephrologists and transplant patients are suggested that they take the vaccine. I'm surprised you didn't ask that question to Dr. Murray.
You know, I forgot.
But the general policy is that we're recommending that dialysis patients and transplant patients take the vaccine. I think there are a lot of good things that have come out of the Black Lives Matter and the pandemic, and that is the appreciation for the discrimination against African Americans. And people are becoming much more sensitive to it. And as a consequence, they're doing things that they weren't doing before. Can you imagine more than 420,000 Americans already dead?
Oh,
and
God.
people are expecting that it'll go up to 500,000 before the summer comes.
All because of Trump. Oh my gosh.
That's not because of Trump. Trump didn't bring the virus here.
Yeah, but I mean, he didn't wear masks, so people,
His behavior was contrary. Yeah, I agree with you.
yeah, I mean,
But he's never responsible for the virus.
yeah, that's true. Yeah.
And we're having a big problem in educating our population, but we have an obligation to do so. Well, it's going to be interesting to see how time. Now, look, AstraZeneca only had 10% African American participation, which is probably more than they've had in the past. But we've come a long way now. Also, keep in mind that the #1 ethnic group is which group?
Black.
#1 Latino Hispanic.
It's Hispanic.
The #1 minority ethnic group is Latino Hispanic. So the goal now is to get more Latino Hispanics, and then of course African Americans as well. But well, that's interesting. Fauci sees getting kids vaccinated by late spring or summer, with the hope that by the fall we'll be okay. And since children seem to handle the virus better than adults, maybe a good case for that. That doesn't mean that kids don't die. It means that they're less likely to die.
Right.
It's not a good thing, but that's an interesting observation, because lung cancer was most common before. Breast cancer still is a problem, although we have improved a lot in its management, but still a far too common cause of death. What's the likelihood that this is going to happen? It will not become a super spreader.
100%.
100%.
I think it's going to be a super spreader. Huh?
They will have Super Bowl parties, and they will spread the virus.
Well, time will come. Was it next Sunday, right?
Yeah.
Oh, this Sunday.
This
right?
Sunday.
Sunday
Yeah.
coming.
Well, one thing, we didn't have a lot of cases after Christmas.
No.
We had after Thanksgiving, but so maybe people are beginning to listen. Well, one thing, you won't have as many people at the game. So you won't have those, what are those parties they call before the games?
Super Bowl, tailgate.
Tailgates, yeah. We won't have as many of those.
I mean, normally you can get 60,000 people in the stadium.
Yeah, at least.
Now it's just 22,000. But that's
Yeah,
a lot of people.
Yeah, still.
And probably people be letting down their guard because the vaccine's out. So they're going to feel a little bit of safety in that. And
I hope not.
Super Bowl parties.
I think you're right. I hope not, though.
No.
We talked the other time about swelling in the face for people who had facelifts. Now swelling of the tongue as a symptom of COVID, although it's not as big a symptom as the others.
Well, my daughter went to the doctor and she was having issues with her anxiety and depression, and she's had it before anyway, but also with her I think it was her calcium levels were low, and the doctor was saying that it was probably post-COVID that was affecting her.
Well, COVID has had so many, affected so many different parts of the body. It's just alarming. Well, that's right. This is this is the closest it comes so far to herd immunity in Israel. It's amazing. We're still so far behind. It's not surprising that Israel is pace setter. Do you think we'll ever get to that level?
I hope so.
Yeah.
The camera's on now. Well, you're not in it.
It's amazing. 72% have already received their second shot. That's great.
You look different. You look different.
Now, this is interesting that 35 to
I don't know, look like your head is. Good.
35 to 49, you know, that's a age that you think would be among the healthier groups. But it's amazing to just read about people dying in an age between 40 and 50. It's scary. More reason why people need to be vaccinated regardless of their age.
For a lot of us, that age group are our children. And so that says that our children are more hard-headed than other age groups.
Yeah.
Yeah, it's our children, yeah.
I agree 100%.
Yes. Yeah.
You can't let them get away with that. You need to fuss at them, scold, you know, do everything, hard encouragement to soften those heads.
I don't think any age group has inherent antibodies for COVID-19. And
That's for sure.
And COVID-19 knows that.
The virus knows that, huh?
Yeah, the virus knows that no one has built-in antibodies for COVID-19, and this is why we're having so much trouble with this virus. So I don't think age group really matters.
Well, it looks like the younger, the people under 10 do better than other groups. That's all you can say. But as you said, there's nobody that has antibodies. But essentially, recovered patients seem to be protected for at least 6 months. There was one article that showed a lady after 10 months who had no antibodies, but at least 6 months they have protected, which points out that you, even if you have had COVID, you need to take the vaccine.
Darryl, do you know whether Rodney has gotten his shots yet?
Yes, he's had his first and second COVID vaccinations.
Oh, good. This is the article that John was talking about, how Biden has emphasized that he's going to make the doses available to pharmaceutical stores. I think churches as well as pharma. I think sometimes we forget that churches are an invaluable area for people. And some people who aren't as computer literate go to churches. And so that's another good launch site for our folks. Okay, how many of you enjoyed the presentation by Dr. Murray?
Oh, I enjoyed it.
Yeah,
Good.
very much so.
Yes, I
Very
enjoyed
thorough.
it. Yes.
Very thorough.
Yeah, okay. And so we have Dr. Johnson, who's the liver transplant surgeon from George Washington. And he's going to be presenting for us on the 18th.
Okay.
And and I'm trying to get some others, and as I do, I'll keep you informed. So when we have those, we'll start off with those people, and then we'll go to the other presentations as time allows.
Is he a liver specialist?
Yes, he's a liver transplant surgeon. Yeah. And he's going to talk about his perspective on liver surgery and liver transplantation. So that's going to be on the 18th. And I'm trying to get some others. So as I get them lined up, I'll let John know, and he'll give them invites. And I'm glad that you appreciated it. I thought that she did a great job of answering questions, no matter how complex they were. For the app group, I got a response from from Mr. Crawford, and so I'll be letting you know when I get that data set up. He's supposed to send me an invite soon, so I'll let you guys know.
I had a quick question. Is anybody else not getting the articles in advance?
No, I'm getting them.
I have a question.
Donald and Stanley are not getting the articles?
No, I haven't received any recently.
Can you put your email in the chat?
Okay.
Sure.
Both of you guys, and I'll make sure. Flavia, I forgot to actually write on the top of those emails that the articles were attached.
They weren't there.
Okay. Yeah.
It may be my system. It may be my firewall or something, but
That's
I
blocking
got them this
attachment.
morning when you sent them after I asked, but they weren't there before.
But that's exactly the same thing I said before.
Yeah, well, I got them today, but not before, so I don't know what
Okay.
happened.
All right.
Darryl has his hand up. Darryl, your hand is up.
Yeah, how many are getting their 3 to 6 servings of fruit every day?
I've had mine already.
Yeah, I'm doing
6 already, 3 already. Huh?
3 already.
And John, I got a bunch of banana strands for you.
Dr. Callender,
Yes.
you think it's possible to have a plastic surgeon on so he could talk about this surgery that they're requiring me to have, this
Yeah, sure.
pancreatectomy?
Okay.
What is
Yes.
that called?
Yes, I'll do that. I'll do that. So I'll let you know when I can. I'll let you know the date that he or she is coming on, because we have a couple of plastic surgeons, and so I'll talk to them.